go from the coracoid process, and one of them inserts onto the lesser tuberosity, or is it tubercle? Tuberosity? Tubercle, whatever. The other one does the greater. Okay? At this point, well, we'll do it for treatment. Don't worry about it. We won't do it now. All right. So, if you remember, the anterior coracohumeral ligament gets tight with flexion. Sorry, with extension. And the posterior one gets tight with flexion. So, scoot your shoulder this way, your bum that way. There you go. Whenever you need your patient to get close to the edge of the bed, that's what you can do for their shoulder. Just bum goes that way, shoulder goes that way. All right. Now, can you imagine, when I show you this test, how did these tests get developed? Earl and Cliff had developed a friendship with the anatomist at the University of British Columbia in Vancouver, UBC. So they would call him up and say, hey, Stan, whatever his name was, we want to come and we want to, mess around with some things for the shoulder. Will you do a pro section and cut this out and leave this on? So they would tell him exactly what they wanted. He would prepare it, and then they'd go over there. It's an hour away from where they live, and then they'd sit there and play, trying to develop tests. They were using the cadavers to try to figure out how can we test these ligaments specifically. That's what they did. So it was good that we were able to validate them, because again, they should have written this stuff and published this stuff up when they did it years ago, and they never did, because they were just clinicians. They were just having fun and whatever. So just get a picture of what it must have looked like when they developed this test in your mind. You have to extend the shoulder. You are going to have to longitudinally distract it and laterally distract it simultaneously. So, unless you've got, 3 hands and/or you're really, really strong, it's going to be hard for you to do that. So for people like me, I'm going to say, is it okay if I put your hand between my knees?
Yes.
Okay? So I do that, I've got my knees bent, and now I can distract her and my hands are free. So now I can stabilize the humerus, the glenoid, and the scapula and the rest of the body, so I don't pull everything out with me, and I can longitudinally distract, and now I can laterally distract. And that is putting the most tension through the anterior coracohumeral ligament. So can you imagine these guys working with a cadaver? And that's what they figured out? Glad I wasn't there. Okay, the posterior coracohumeral ligament is tight in flexion. You don't put it in external rotation, but you don't put it in full internal rotation. You just kind of have it like this. And this one, you have to simultaneously push it towards the floor while you're simultaneously pulling it towards the feet. So to do that, you've got to put their elbow right here on you so that I can use my body now to help me push down towards the floor and hold that there now with the weight of my upper body, and then I can pull in down towards her feet simultaneously. Okay? So again, you will not feel any laxity on this, but if these ligaments are painful, you would reproduce their shoulder pain. Okay? So this one, stabilize, get in here, distract, laterally distract. This one, push down towards the feet. Okay? So that's that. Now while the person's lying down, I'm going to show you the Earl's anterior and posterior capsule test. Because you're right here, so. What you're going to do is you're going to maximally internally rotate. Does that tension the anterior capsule or the posterior capsule?
Medial rotate for posterior capsule.
Okay, so this is the posterior capsule test. Okay, so you maximally internally rotate the humerus and the forearm. What you need to be doing up here is feeling. Okay, you're not going to be stabilizing anything, you're just feeling. Okay, and in this position, when I distract, do I feel at this acromion process here, do I feel the head of her humerus significantly moving downward, like a sulcus sign? Okay? Because if everything is intact in the posterior capsule, when I maximally internally rotate her arm, there should be little to no movement here. When you do the sulcus sign, all I feel is about a millimeter of movement, and it comes to a dead stop. Similarly, for the anterior capsule, we're going to do the exact opposite, and we're going to externally rotate the humerus as far as it'll go. Okay, and I'm going to palpate, and now I'm going to try to distract. Okay, and even on this one, there's little to no movement. If they have a torn superior anterior labrum slap lesion, this test will be positive. You will feel gapping. This is one of these tests that you should feel nothing other than a little millimeter of soft tissue give. But if you feel gapping, it's a positive test. Okay? So they either have a positive labral tear or they have a positive anterior capsular laxity, either or. Okay? So you've got 3 tests. You've got your